So I want to move now to part 2 of my talk, in which I discuss a little bit more about particulars, like particular community, like autism in a group of poor African American women, or autism in the world of South Koreans in Seoul. We know very little about autism internationally. I mean, we know a lot more than we did 10 years ago, thanks to some of the people in this room, too. But we also simply don't have good data from around the world. I know Grace alluded to this. But even in the United States, we don't understand how variations within our own country will influence the identification and management and understanding of autism. Even in Canada, you have serious underdetection of autism among First Nations groups. There are later ages of identification of autism in rural communities, and there is a parallel in the United States where African American children are diagnosed much less often and much later. If any of you saw the CDC statistics from a couple of years ago, you saw big increases in diagnoses of autism among African Americans. And lots of the media said, oh, why this huge jump in African Americans? Are they getting autism more? And there were others like me who said, oh, now they're getting treatment. Now they're getting intervention. Now they're getting identified. You see these things in different ways. As I tell my students in Introduction to Anthropology, once they're finished with the 15-week course, I'm not sure they're going to be able to answer the question, what is culture? It's a complicated term. It's a very hard one to pin down. It can mean so many things. But I would like to offer a few guidelines for how we might think about culture in our profession of working on autism. So it definitely is the public patterns of meaning that involve some degree of consensus, shared meanings. Now, this doesn't mean that we can say that South Asians think this way and Koreans think that way or whatever, but when we talk about culture, we are looking for something shared, not just for one person's individual perspective. It is not necessarily, as I just said, homogeneous. In Mary J. Good's work on diversity in Boston, she notes how much difficulty people in emergency rooms had trying to figure out what the classification should be, ethnic or racial, of the people who came into the emergency room, because they all were like, a quarter this, an eighth that, and they couldn't figure it out. She calls it hyperdiversity. Culture is also not the last resort after looking at all other possible factors to explain what you want to explain. Sometimes people will say, well, I've done all the quantitative work, and I've done everything else, and I've looked at the economics, and I've looked at this. It must be culture. As if culture isn't involved in other sorts of things, as if quantification and statistics are themselves not a cultural language. Also, culture is not just a barrier. I think this is one of the most important. Culture is not just a barrier to overcome. Often medical students or clinicians that I interview will say, so Professor Grieger, so how do I get rid of the cultural stuff so I can treat the patient? You don't get rid of it, both because you have your own culture as a clinician, and also because that person is defined, their interpretations, their views of the world are defined in part from their background. So the question is, how can we incorporate our knowledge of somebody else's meanings, culture, into a meaningful communication, into a place in which the patients or the families feel that they're being heard, feel that they are being appreciated, where they have a voice and they're not just being kind of put down in a hierarchical relationship. Finally, culture is not always the most important factor. Sometimes poverty, homelessness, things of that sort will trump cultural difference. Oh, I hate the word Trump. Sorry. Shouldn't have used it. Take, for example, the rich person the rich person in Vancouver and the poor person in Vancouver, the rich person in New Delhi and the poor person in New Delhi. We could, in some ways, say that the rich person in New Delhi and the rich person in Vancouver are culturally more similar to each other than the rich or the poor are in any one of those locations. So sometimes there are certain factors that just simply are far more important than whether somebody, depending on what you're trying to explain, of course. An issue that frequently comes up in understanding culture in autism is whether clinicians and teachers are misinterpreting behaviors that have a cultural foundation, meaning that there is a shared understanding that a particular behavior is within the realm of the normal in that community. So, for example, well, in my culture, it's not polite to look people in the eye. So why is the clinician talking about eye gaze? My child's being evaluated through play with an adult, but in my culture, adults and children don't play together. The doctor told me my child never points to anything, but in my culture, children are not supposed to point. And when we published our epidemiologic study of autism in Korea, there were some critics who said, yeah, but how did these people understand what was good, appropriate eye gaze or whatever when Koreans believe that children should not be looking into the eyes of their adults? There are two answers to this. Well, the first is that the diagnoses that were made in our study were made by an international team, including Koreans, who were trained in the ADOS and the ADI. But the more important answer to this is that autism should be diagnosed on the basis of numerous characteristics, so that any one particular issue that might have a cultural bias in interpretation is not going to have as much power as the pattern, as the overall pattern. Plus, every society has its own views of what is normal and abnormal. Because South Korean children might be seen as polite to avoid some eye contact with an adult does not mean that all diversion of eye gaze is normal. Everybody can identify what they consider to be appropriate or not, no matter where you are, no matter what culture you are in. It is also true, though, that there could be presentations of autism that are culturally specific. Amy Weatherby and I did research with Mexican immigrant families in southern Florida and found that the first symptom that parents presented about their children's autism was that they were picky eaters. Whereas in other communities, that may not be the first thing that people raise. One of the things that came up in my work in Korea was children's inability or difficulty to, when they were able to use language, was that an inability to use language to reference social hierarchy. So there are honorifics in the Korean language. There are suffixes that indicate the kind of person that you're speaking to. So I've just put the word hello up here, which, in the most simple form for a little child, if I'm going to see a little child here, I'm going to say annyeong. There's no suffix at all. But if I see somebody who's, I don't know, but they're sort of my age, but it's, it's formal enough because they're not my friend, I probably say annyeonghaseyo, although increasingly a big issue in Korea is people are dropping the yo. Then the more deferential annyeongha십니까, which is hyper formal, and I don't hear it very much anymore. But what happens is that in an English-speaking community, pronoun reversal is common and associated with echolalia, in which a child says, when a child is hungry, the child says, "You're hungry?" So they're reversing the pronouns. But in Korean, pronouns aren't used that often, or at least not as often as they are in English. And so the linguistic marker is something else, and often also a behavioral. Like I can't get like a mother with two children, one with autism, one without autism, and the autistic child is the elder, and he keeps bowing to his younger brother, right? And he can't get that social referent that the older brother's shouldn't be bowing to his younger brother. Even in cultures that you would think similar, England and the United States, England and Canada, France and the US, have differences in how they think about autism, how they identify it, explain it, and present it to parents.